In this disease, there is migration of thrombus into the pulmonary artery. So, what is this disease referred to as? It is pulmonary embolism. So, it is migration of thrombus into the pulmonary circulation, and this is referred to as pulmonary embolism. So, write down the definition. It is migration of thrombus, migration of thrombus into pulmonary circulation. This pulmonary thromboembolism, the predisposing factors can be divided into genetic, acquired. Under genetic, we have protein CS deficiency, factor 5 Leiden mutation, factor 5 Leiden mutation, hyperhomocystinemia, hyperhomocystinemia. So let it be any of this. The end result is hypercoagulability. The tendency of your blood to form a thrombus increases. Whereas acquired causes, we have recent trauma or surgery, prolonged immobilization, prolonged immobilization, then it can be due to pregnancy, malignancy, then estrogen containing. Why will estrogen containing pills be a risk factor? Because these pills have a side effect called as deep vein thrombus formation. Then there is varicose veins. So why varicose veins? Because these are the structures that can harbor deep vein thrombus. Then nephrotic syndrome. How come nephrotic syndrome is responsible? In nephrotic syndrome, like all other proteins in the urine, there will be loss of antithrombin 3. So whenever antithrombin 3 is lost, the tendency of your blood to get coagulate increases. So loss of antithrombin 3 will result in hypercoagulability. And finally, infections such as COVID. So why it happens in COVID? When I discuss COVID, I will let you know. So these are the various predisposing factors for development of pulmonary embolism. Now you know that your pulmonary artery is a connection between your heart and your lung. So whenever there is some problem in the pulmonary artery, there can be events happening in the lung, events happening in the heart. So we will discuss the pathophysiology with respect to what happens in the lungs, what happens in the heart. So make a table on one side. What is happening in the lung, what is happening in the heart. Consider this is your lung. Let this be the bronchus, finally giving rise to tiny structures called as alveoli. And on the surface of your lung, most important blood vessel is your pulmonary artery. So let this be the lung with various airways, and let this be the pulmonary artery with many branches. Now the issue here is there is a thrombus in the pulmonary artery. Now just before the thrombus there can be increased pressure, increased pressure within vessel. Because of increased pressure within vessel, it can be responsible for rupture. So whenever the vessel is getting ruptured, there can be hemoptysis. Now consider this is a freely flowing blood vessel. So when there is a thrombus or when there is an obstruction, just before the obstruction, there can be increased pressure in the vessels, it can rupture. Then as long as there is obstruction, there will be no proper transfer of gases in that area. So there will be decreased transfer of oxygen that will be responsible for hypoxemia. Because there is a hypoxemia, whenever there is less oxygen, your body will fight by hyperventilation that result in a discomfort in breathing called as shortness of breath. When there is a thrombus, around the thrombus, platelets can aggregate. So there can be lot of platelets in that thrombotic area. Now these platelets are known to produce serotonin, and this serotonin can be responsible for bronchospasm. So once there is bronchospasm, that bronchospasm can transiently increase airway resistance. So bronchospasm can increase airway resistance. Next, as time progresses, the amount of blood reaching your lung can gradually decrease. That results in lung ischemia. Because of lung ischemia, there can be damage to the cellular workup of the lung. So there can be damage to the cells within the lung. So whenever there is damage anywhere, there will be release of inflammatory mediators and ongoing inflammation. Now this inflammation, if it progresses to the pleura, there can be pleuritis. So what can happen when there is pleuritis? There can be chest pain. As a reaction to pleural inflammation, there can be formation of pleural fluid, and this pleural effusion is due to inflammation. It will be generally exudative in. So there is inflammation that can result in formation of pleural effusion, and that is generally exudative in nature. If somebody asks me what are the presenting features of this pulmonary embolism, patient can present with acute shortness of breath, hemoptysis, and chest pain. Acute shortness of breath, hemoptysis, chest pain. Next, coming to features in the heart. Actually, heart features generally happen whenever there is a large thrombus. Consider this is your heart. Let this be right atrium, right ventricle, left atrium, left ventricle. And between the ventricles, there is a good interventricular septum. So, what is the vessel coming out from your ventricle called as right ventricle? Pulmonary artery. The vessel coming out from the left ventricle is the systemic aorta. Now, the issue here is whenever there is a significantly large thrombus in the pulmonary artery, what will be the heart manifest? Initially, your heart will try to fight against this thrombus. It will try to push the thrombus. So, when it is trying to push the thrombus, there will be increased right ventricular pressure, and also your right ventricle will dilate. So this right ventricular dilatation, it will not only be sidewards, it will also be medially. So whenever your right ventricle is dilating medially, the interventricular septum will be pushed more into the left ventricle. The interventricular septum will be pushed more into the left ventricle. So there will be increased movement of interventricular septum, increased movement of interventricular septum into left ventricular cavity. Because of this excess movement into left ventricular cavity, so what can happen? There will be underfilling. There will be underfilling of left ventricle that can be responsible for reduced cardiac output, that can be responsible for reduced cardiac output, that can translate as hypotension and ultimately shock. So this excess movement of interventricular septum into left ventricular cavity will cause underfilling of left ventricle, reduced cardiac output, ultimately hypotension and shock. And my right ventricle cannot tolerate such high pressures for long. It will give up, resulting in right ventricular dysfunction. So if somebody asks me what are the manifestations with respect to heart, right ventricular dysfunction, hypotension, shock. Now what is this entity called as? Right ventricular dysfunction due to primary respiratory cause, excluding diseases of left heart called as. Generally, right ventricular dysfunction happens due to back pressure, due to left heart disease. That is the usual mechanism that we have seen previously. Now, here there is no left heart disease at all, but still there is right ventricular dysfunction. So, this right ventricular dysfunction due to primary respiratory cause, it is called as cor pulmonale. You must be knowing this pulmonary artery is a part of respiratory system. Aorta is generally part of cardiovascular. There is no left heart disease, but still there is right ventricular dysfunction. This entity is generally referred to as cor pulmonale. So this cor pulmonale, let us see students, it is defined as right ventricular dysfunction. Right ventricular dysfunction due to right ventricular dysfunction due to primary respiratory cause, excluding diseases of left heart. It is right ventricular dysfunction due to primary respiratory cause, excluding diseases of left heart. And this cor pulmonale can be further classified into acute cor pulmonale and other is chronic cor pulmonale. Acute cor pulmonale, just now we have discussed. Most common cause is pulmonary embolism, whereas chronic cor pulmonale, most common cause of chronic cor pulmonale is COPD. Apart from this, chronic lung diseases such as ILD, bronchiectasis, obstructive sleep apnea, OSA. All these are responsible for chronic cor pulmonale. Now the question arises, how will a chronic respiratory disease be responsible? Now all this will cause long-standing hypoxemia in long run can cause persistent pulmonary vasoconstriction. This persistent pulmonary vasoconstriction is actually mediated through hypoxia sensitive potassium hypoxia sensitive potassium channels present in the pulmonary vasculature. Because of this persistent pulmonary vasoconstriction, there will be pulmonary hypertension. My right ventricle cannot tolerate such huge pressure for long. It will give up, resulting in cor pulmonale. So, resulting in right ventricular dysfunction. So, that right ventricular dysfunction, as it is due to primary respiratory cause, this is nothing but cor pulmonale. Now, the big question here is how will a pulmonary disease be responsible for pulmonary vasoconstriction? So, it is due to hypoxia. So, whenever there is hypoxemia, your pulmonary vasculature is having a special feature. What is that special feature? Hypoxia sensitive potassium channels. Whenever there is less oxygen, these potassium channels will react and it will change the membrane potential, resulting in pulmonary vasoconstriction. So, this pulmonary vasoconstriction is due to hypoxia sensitive potassium channel. Because the pulmonary vasculature is constricted, there is pulmonary hypertension, and my right ventricle cannot tolerate this, resulting in right ventricular dysfunction and cor pulmonale. Up to now, we have discussed, students, the clinical features of pulmonary embolism and also predisposing factors. Now, integrating these two, there is a scoring system by which you can predict the likelihood of pulmonary embolism in a given patient. So, this is called as Wells scoring for pulmonary embolism. So, PE means pulmonary embolism. So, these are the variables that we take into consideration. If patient is having signs and symptoms of DVT, 3 points. Alternative diagnosis less likely than pulmonary embolism means strong clinical suspicion. Strong clinical suspicion of pulmonary embolism. So, you feel it is pulmonary embolism. Heart rate more than 100, 1.5. Immobilization more than 3 days, surgery within 4 weeks, 1.5. Prior pulmonary embolism, 1.5. Patient has presented to you with hemoptysis, 1 point. Patient is having malignancy, 1 point. Now, if you do a question, you can understand the utility. Now, say for example, there was a 75-year-old male patient. He was having colon carcinoma. He recently underwent surgery. And within the hospital, now he is having hemoptysis and his heart rate is 110 per minute. What will be the total score according to this system? Now, let us see point by point. Because he is having malignancy, so 1 point. Recently underwent surgery, 1.5. Hemoptysis, another 1 point. Heart rate is 110 per minute, so more than 100. For this also we give another 1.5. So, now if you make total of all these components, 1.5 plus 1.5, 3. 3 plus 1, 4. 4 plus 1, 5. So the total score is 5. Now, what is the clinical utility of this scoring? Now, with this scoring system, if any patient's score is more than 4, so this is very important. Any patient's score is more than 4, it means high chances of having pulmonary embolism. So he is having high likelihood of pulmonary embolism. So with this scoring system, we will have two categories of patients. Patients with high score and other patient will be patient with low score. What will you do next will be frequently asked in your exam. If patient is having high score, the chances of pulmonary embolism in his body is high. So don't waste patient's time. So next step should be investigation of choice called as CT pulmonary angiography. Now, if the patient's score is less, the chances of pulmonary embolism is less. So, first we do a 500 rupees blood test called as D-dimer. So, we do a 500 rupees blood test called as D-dimer. Only if it is high, if the D-dimer value is high, then we go for a 10,000 rupees test called as CT pulmonary angiography. If D-dimer is normal, we can exclude pulmonary embolism. How normal D-dimer excludes pulmonary embolism, I will discuss in the next slide. Now let us see the practical aspect of. Now if at all patient is having high score, it means the chances of pulmonary embolism is high. In this situation, don't waste patient's time. Immediately go for investigation of choice CT pulmonary angiography. If patient is having low score, the chances of pulmonary embolism is low. In this situation, don't waste patient's money. First do a 500 rupees blood test called as D-dimer. Only if it is high, then go for 10,000 rupees test called as CT pulmonary angiography. If at all D-dimer is normal, you have not only excluded pulmonary embolism, but you have saved 10,000 rupees for the patient. That is more important nowadays. So it means if the score is high, don't waste patient's time, immediately go for investigation of choice. If the score is less, don't waste patient's money. First do a 500 rupees blood test. Only if it is high, then go for CT pulmonary angiography. If D-dimer is normal, you can actually exclude pulmonary embolism. Now let us see what are all the investigations helpful in diagnosis of pulmonary embolism. So let us start with the simple ECG. So within ECG, most common finding, if somebody asks me, my answer will be sinus tachycardia. So within the ECG, most common finding is sinus tachycardia. Along with that, one can also notice T wave inversion, suggestive of right ventricular strain pattern in the leads V1 to V4. But most specific pattern, what is special, famous for this pulmonary embolism? It is the classical S1 Q3 T3 pattern. So what is this S1 Q3 T3 pattern? So we will be discussing later. Then coming to the chest X-ray findings, because it is primarily a problem in the pulmonary artery, not in the lung parenchyma. Chest X-ray most often, chest X-ray most often tends to be normal. chest X-ray most often tends to be normal. But there are few special findings. So once again, students, so these are rarely seen. No need to waste your time on a chest X-ray searching for a thrombus. So what are these special findings? Consider this is your lung. So let this be the lung, comfortably sitting on the diaphragm, and let this be the heart stat. And most important blood vessel on the surface of the lung is your pulmonary artery. So let this be the various branches of pulmonary artery for example. So whenever there is a thrombus in a blood vessel, just distal to the thrombus, all this vasculature might disappear. So because there is an obstruction distal to that thrombus, the vasculature might automatically disappear. Now this area of less vasculature, this area of less vasculature, it is referred to as Westermarck's sign. So first important finding is area of less vasculature, focal aligemia. So this focal aligemia is referred to as Westermarck's sign. It is referred to as Westermarck's sign. As time progresses, the amount of blood reaching the lung will reduce, and there can be a wedge-shaped opacity due to lung infarction. So this wedge-shaped opacity, this wedge-shaped opacity, this wedge-shaped opacity due to lung infarction, it is called as the famous Hampton's hump. It is called as the famous Hampton's hump. Hampton's hump. Then coming to the next sign, it was particularly described when the thrombus was seen in the right descending pulmonary artery. On the chest X-ray, your right descending pulmonary artery is an important structure. So whenever there is a thrombus in the right descending pulmonary artery, just before the thrombus, there can be stasis of blood and there can be dilatation of right descending pulmonary artery. Now this dilated, this dilated right descending pulmonary artery, this dilated right descending pulmonary artery, this dilated right descending pulmonary artery was referred to as Palas sign. Try to understand this simple sign. See here, this is a freely flowing right descending pulmonary artery. Now, whenever there is an obstruction, just before the obstruction, there can be stasis of blood resulting in dilatation. So, if you consider this is a freely flowing right descending pulmonary artery, whenever there is an obstruction, just before the obstruction, there can be stasis of blood resulting in dilatation of that blood vessel. So, the dilated right descending pulmonary artery is also called as Palas sign. So, once again, let it be this Westermarck sign, Hampton's hump, or Palas sign are not that common in clinical practice. Then, in majority of the patients, I should send for a lower limb venous ultrasound. So, why I should send for a lower limb venous ultrasound? To rule out any possibility of deep vein thrombus. And if at all you do a 2D echo, one can notice your right ventricle has given up. And this right ventricular hypokinesia in setting of a thrombus in the pulmonary artery. This was described as McConnell's sign, right ventricular hypokinesia. In setting of a thrombus in the pulmonary artery, it was described as McConnell's sign. Then, coming to an important blood test called as D-dimer. This D-dimer, write down, I'll describe. It is a fibrin degradation product. It is a fibrin degradation product. It is generally elevated in pulmonary embolism. Elevated in pulmonary. It is a sensitive test. It is sensitive but not specific. It is sensitive test but not specific. Why it is not specific? It is also elevated. It is also elevated in situations such as sepsis, DVT, cancer, etc. Sepsis, DVT, cancer, etc. This test actually has a good negative predictive value. Good negative predictive value. But poor positive predictive value. But poor positive predictive value. And because it is having poor positive predictive value, this is used only as screening test, not investigation of choice. Now let us see what is this D-dimer actually. See, whenever there is a thrombus in your body will fight against that thrombus by gradually breaking it. So whenever a thrombus is broken down, some fragments will be released into circulation. So one such fragment is actually D-dimer. One such fragment is D-dimer. So if D-dimer is elevated, it means there is some thrombus being broken down abnormally in your body. So definitely in pulmonary embolism, D-dimer will be elevated. Now the problem here is it is not that specific. So why it is not specific? Say for example, there is a thrombus in the upper limb, in the abdomen or in the lower limb. In all these situations also D-dimer will be elevated. If D-dimer is elevated, it means there is a thrombus existing in your body. But it does not clearly say that this thrombus is only present in the pulmonary artery. It has good negative predictive value. Negative predictive value means exclusion, ability to exclude. Poor positive predictive value. Positive predictive value means ability to confirm. Now you only tell me, students, there is a patient with high D-dimer value. With this single test, can you confirm it as pulmonary embolism? No. This high D-dimer value can be due to thrombus anywhere in your body. Now, without CT pulmonary angiography, you cannot confirm it as pulmonary embolism. So, this D-dimer cannot be used as a test for confirmation. Now, for example, the D-dimer value is normal. If D-dimer value is normal, what does it mean? The chances of abnormal thrombus broken in your body is less. So the chances of abnormal thrombus existing itself is less. So it can be used as a test for exclusion. That's why it is having good negative predictive value. So how is D-dimer helpful? High D-dimer cannot confirm it as pulmonary embolism because that high D-dimer can be due to thrombus anywhere in your body. But if the D-dimer value is normal, it means there is no thrombus being abnormally broken down in your body. It means the chances of abnormal thrombus existing itself is also less. So it is a test for exclusion, not for confirmation. That's why it is used only as screening test. Then, what do you mean by investigation of choice? It should be easily available, easily done, good sensitivity, specificity, less complication. Such qualities are seen in CT pulmonary angiography. So, what you do in CT pulmonary angiography, you are going to inject contrast material into the patient's blood vessels. So, what is the property of contrast material? Wherever there is blood, it will make that area appear very white on a CT. Definitely, pulmonary artery will appear very white in that CT film. In that area of white, if you see anything less white, it is nothing but thrombus. Because this investigation is clearly showing you thrombus in the pulmonary artery. Easily done, less complications, good sensitivity and specificity. It has become the investigation of choice. Then, gold standard test. It might be difficult to do. It might be associated with complications, but if you do it, you are 100% sure. Such a test was previously done, referred to as invasive pulmonary arteriography. So here it is not just the contrast, you are directly inserting a catheter into the pulmonary artery. Now you know you are in pulmonary artery, but it is not moving beyond a point. It means that there is an obstruction. But it is an invasive method, can be associated with complication. For simple diagnosis, nobody is going to use this invasive method. So right now, for diagnosis, nowhere we are using this invasive pulmonary arteriography. Now in 99% for diagnosis, this is the investigation of choice, and also it has become near gold standard. So in majority, we are using CT pulmonary angiography. So it has become near gold standard for diagnosis of pulmonary embolism. Now before the advent of CT scan, in our country we were doing an old test called as ventilation perfusion scan. But this sensitivity and specificity is not good as compared to CT pulmonary angiography. Now its use has been declined significantly. It is used only in limited situations where, number one, where you cannot give contrast material. Either patient is having contrast hypersensitivity or patient is having some renal disease. So that is contrast intolerance. And second, if you don't want the mother to get exposed to huge amounts of radiation pregnant. So when you give contrast material to a patient with renal disease, it can result in renal failure. So you should not do this CT pulmonary angiography in contrast intolerance. There you can do this ventilation perfusion scan. But in pregnancy, I have put a question mark now, because nowadays the recent CT missions are having an option of adjusting the radiation and doing low dose CT pulmonary angiography. By grace of God and COVID, now all the hospitals have their own CT mission. So the modern CT missions you can do in pregnant females also, because you can adjust the radiation dose there. So nowadays the only indication for ventilation perfusion scan will be contrast intolerance, whereas in pregnant you can go for low dose CT pulmonary angiography. So these are the various investigations that we do for pulmonary embolism. Once you have investigated and diagnosed, next will be the treatment. Treatment generally depends upon the presentation. So we have three types of presentations. One is massive pulmonary embolism, a big thrombus, highly unstable patient, also called as high risk pulmonary embolism. So why we call it as high risk pulmonary embolism? Because there is high risk of mortality in this. Then we have submassive pulmonary embolism or intermediate risk. Then we have minimal pulmonary embolism. So a small thrombus, low risk of mortality. So massive pulmonary embolism is also called as high risk PE because of high risk of mortality. So what will be the presentation here? Here the presentation is very bad. Patient presents with shock and right ventricular dysfunction. Whereas submassive, here BP will be maintained, but still there can be some amount of right ventricular dysfunction. Whereas minimal, nothing to worry, normal BP and normal RV function, normal right ventricular function. Now, how will you manage this patient? Because this patient is presenting with shock. So, initial treatment will be stabilizing the patient with 500 ml NS to improve BP. You can add vasopressors and you can add anticoagulation. You should start anticoagulation. So, what is the role of anticoagulation? It will prevent the extension of thrombus. It will also prevent the chances of re-thrombosis. But if somebody asks me, what is the definitive treatment? Now, there is a large thrombus resulting in obstruction, shock. How will I save the life of the patient? By breaking it down. So you have to break it like this. So what is this called as thrombolysis? It is a type of reperfusion treatment. If thrombolysis cannot be done due to any reason, you can go for surgical embolism. So break the thrombus like. Whereas submassive, because BP is good, you can start anticoagulation and closely monitor the patient and closely monitor the patient. If patient develops hemodynamic compromise, if patient develops hemodynamic compromise, you have to treat it similar to massive by doing thrombolysis. Whereas minimal, a small thrombus, just anticoagulation is sufficient. Frequently, majority will get confused between the management of massive pulmonary embolism and submassive pulmonary embolism. See here, in massive, in majority, what should be definitely done? Thrombolysis. In submassive, first do anticoagulation. If patient is improving with anticoagulation, there ends the matter. If patient is not improving, then only you should go for thrombolysis. In simple words, in massive pulmonary embolism, thrombolysis is done definitely in majority. In submassive, you do anticoagulation. Only if patient is not improving, then you go for thrombolysis. So in massive, it has to be done definitely in majority. In submassive, it is only done selectively in patients not improving with anticoagulation. So here it is definite. Here it is only in selective case. Then what are the drugs that we use for thrombolysis? Nowadays, we are not using this streptokinase because of hypersensitivity reaction. We use recombinant tissue plasminogen activators and common is altiplase. But the problem with thrombolysis is there can be bleeding complication. So there can be increased bleeding complication. I'll also tell you how to counter this later on. And as a part of anticoagulation, we have traditional regimen, that is heparin bridged to warfarin. Bridged means combined with warfarin. Heparin followed by dabigatran. So this dabigatran is nothing but direct thrombin inhibitor. Then we have apixaban, rivaroxaban. So these are nothing but factor 10A inhibitors. Apixaban, rivaroxaban are nothing but factor 10A inhibitors. So anticoagulation, the cheapest regimen is heparin combined with warfarin. Other regimens, heparin followed by dabigatran or monotherapy with rivaroxaban, apixaban. So to curtail this bleeding complications, there is a new type of thrombolysis done nowadays. See, what is conventional thrombolysis? You give the drug through IV route. So it will not only go into the pulmonary artery, because you are giving it through a peripheral vein, so it can go to various parts of the body. Say for example, this patient is having some unnoticed gastric ulcer. Now it can bleed, resulting in fatal GI hemorrhage also. To bring down this bleeding complications, nowadays in higher centers we are doing a new type of thrombolysis. So we put a catheter directly into the pulmonary artery under imaging guidance. We go to the area of thrombus, we inject the drug directly into the thrombus. Because we are directly injecting the drug, the dose required is less, the complications will also be less. So this direct intraclot infusion of thrombolytics is called as catheter directed therapy. The biggest advantage here is reduced bleeding complications. So under imaging guidance, what we are going to do, we are going to insert a specialized catheter like this, and we see the thrombus, we are directly injecting the drug into the thrombus. Because we are directly injecting the drug into the thrombus, dose required is less. If dose is less, the complications is also less. This is called as catheter directed therapy. It is a treatment practiced in advanced centers. Now let us see some images and questions with respect to pulmonary thromboembolism. So this is a classical S1 Q3 T3 pattern. So one can notice deep S waves in lead 1, Q waves in lead 3 and inverted T waves in lead 3. Actually, nobody knows what is the precise mechanism behind these findings. So maybe, especially in massive pulmonary thromboembolism, there is change in anatomy and physiology of your right ventricle. Because of this anatomical and physiological changes in right ventricle, these changes might be evident. And this was a finding seen especially in massive pulmonary thromboembolism. But if you are asked what is the most common ECG finding, it is generally sinus tachycardia. Most common is generally sinus tachycardia, whereas special is the classical S1, Q3, T3 pattern. Now let us solve a question. This was a 75-year-old male with history of colon cancer, admitted to the ICU for 5 days. There is sudden onset dyspnea, chest pain and hemoptysis. His BP, heart rate, SpO2 is less, respiratory rate is high. No edema or tenderness in the lower limbs. ABG is showing type 1 respiratory failure. Chest X-ray normal. Which of the following diagnostic test in order to confirm? Keyword, order to confirm. First of all, if you see a patient like this, patient is having malignancy, he is immobilized in ICU, dyspnea, chest pain, hemoptysis, heart rate, all these are suggestive of classical pulmonary embolism. So in pulmonary embolism is your suspicion. How will you confirm pulmonary embolism? Confirm means only single option. Multi-detector CT pulmonary angiography. This was a case that I have seen in my practice. I also have done a CT pulmonary angiography. This is the image. So what is this structure? It is the main pulmonary artery. Why is it very white? Because it has been filled with contrast. In that area of white, if you see anything less white, it is thrombus. Because this investigation is localizing the thrombus precisely, easily available, easily done, less complications, good sensitivity and specificity. Now, this is the investigation of choice, CT pulmonary angiography. So, this is regarding very important disease called as pulmonary thromboembolism.